revising all this both the subjects this week. We can go ahead with the discussion now. The first question was Cauda-Equina syndrome is associated with which of the following anesthetics? The options being lidocaine, halothane, nitrous oxide, and ether. So basically, we know that Cauda-Equina syndrome is associated with local anesthetics. You have to rule out the options which are not fitting into the question. Ether being an inhalational anesthetic, into being an inhalational, halothane also being an inhalational, don't fit into the question. So the right answer being lidocaine. Moving on to the next question. This was a recent FMG question, and hence I had put it in the quiz. We'll go to the next question. Laryngeal mask airway is contraindicated in what? Difficult airways, ocular surgeries, pregnant females, or in CPR. So basically, the contraindications of laryngeal mask airways are the conditions associated with high risk of aspiration, including full stomach, hiatus hernia, pregnancy, or the conditions which involve oropharyngeal mass or abscesses, massive thoracic injury, or massive maxillofacial trauma. Among the options, the most appropriate option would be pregnant females as they are associated with high risk of aspiration. So, we'll not be using LMAs in them. Move on to the next question. Etomidate is not used for long-term infusion because of what complications? Option A, adrenal suppression. Option B, vasospasm. Option C, cardiac arrhythmias. And option D, increased ICT. This was also a recent FMG question. And most of you have got it right. The option being adrenal suppression. We know that etomidate is known to cause adrenal suppression, and hence it is not used for long-term uh, infusion. The mechanism by which it causes adrenal suppression is by reversibly inhibiting 11 beta hydroxylase. However, it is also known to have a minor effect on 17 alpha hydroxylase.
Yeah.
Moving on to the next question. This was a trickier one, and hence we can see that only 8 of you have got it right. We can go with the question. Triangle of Petit is a landmark for which block? I've just given a reference diagram in the question. So there are two important triangles, lumbar triangles, triangle of Greinfeld and triangle of Petit. These are the common triangles where lumbar hernias occur. That will be covered in surgery. But for now, we need to know that triangle of Petit is a landmark used for which block. So options being spinal block, Bayer's block, TAP block, and epidural block. So most of you have been able to rule out spinal and epidural because we know that spinal and epidural has to be in the midline where the spine is. So there was quite a bit of confusion between Bayers and TAP. Most of you might not have heard of TAP and hence the confusion. However, we know that Bayer's block is usually used for extremities with a tourniquet, and it was also a recent 2024 NEET question. The answer was TAP block, which is a peripheral nerve block designated to anesthetize the nerve supplying the anterior abdominal wall around T6 to L1 dermatomes. The point of entry for this type of block is through the Petit triangle or the triangle of Petit. We'll move to the next question. While trying to secure a central venous catheter, there was development of high airway pressure, increased resistance, and sudden desaturation. What is the most probable diagnosis? Okay, so again, we can see that most of you have ruled two options, but there was quite a confusion between pneumothorax and air embolism, and most of you, majority of you, have gone with the wrong option. The thing is, central venous catheter we can insert through IJV or subclavian. We need to know what they are talking about. So in this question, we can know that we also know that pneumothorax is the most common complication for central venous catheter insertion, which represent around 30% of the adverse effects of CVC. The clue was sudden desaturation and increased resistance. Air embolism is also associated with sudden desaturation. However, we know that increased resistance is and high airway pressure is mostly associated with pneumothorax. So the right option was pneumothorax. And anyways, air embolism, pneumothorax is more commonly associated with subclavian vein insertion. That thing you have to know. Then IJV insertion. This is also a test question, potential question. Moving on to the next question. Hypotension following spinal anesthesia can be best prevented by option A, preloading with colloids, option B, using small size needles, option C, preloading with crystalloids, option D, all of the above. So most of you have gone with the safer option, which was all of the above. But safe is always not always right. The answer was preloading with colloids. Hypotension is one of the most common complications of spinal anesthesia, as we all know. But we know that it occurs mainly due to blockage of sympathetic fibers. However, we can always note that hypotension, when occurs in spinal anesthesia, is always associated, usually associated with bradycardia. The important thing to note is that we can prevent it by preloading it with colloids. Also, by uh, upright posture known as beach chair position. These two methods can prevent hypotension following spinal anesthesia. Crystalloids get redistributed into intravascular and extravascular compartment pretty quickly, and hence we can't use them following spinal anesthesia to prevent hypotension. So option C and D automatically uh, become wrong. However, option B being using small size needle has no effect on hypotension. We'll move on to the next question. If you are asked to collect four serial samples from lumbar puncture, what should be the first sample? This was a NBME question, USMLE question. Uh, INI people usually love to pick from USMLE, and most of us don't have access to USMLE question. I had gone through some of the USMLE questions also, and I think this was a potential question, and hence I had used this for the quiz. We can see that this was quite a tough question, and most of you have gone with bacterial culture and gram staining. We usually think of LP as mainly for the culture or staining. However, we need to know that as soon as we collect LP, we collect it in four tubes. This is the routine methods. So, classic approach of collecting LP is through four CSF tubes. Tube one, we usually use it for cell counts and differential counts. Tube 2 for glucose and protein. Tube 3 for gram stain, culture and sensitivity. And tube 4 for, again, we can go back to cell counts and differentials. So, since we had asked what should be the first sample, the option was cell counts like differential counts. Though bacterial culture and gram staining are important, they are the third sample, that is on the third tube 3. Mycobacterial and fungal culture don't have a separate tube. These are in order: A, tube 1, tube 2, tube 3, and again tube 4. We'll move on to the next question. A patient with uterine fibroid suffering from moderate to severe cardiac ailment. Which of the following should be avoided? Again, an USMLE question. We can see that some of you have got it right. This was quite a difficult question, actually. Happy for those who have got it right. The important thing to note is that in a patient with uterine fibroid also having a cardiac ailment, lap hysterectomy is avoided because we know that anesthetic drugs usually cause myocardial depression. And in on top of that, if we use a laparoscopic surgery, because of creation of pneumoperitoneum through insufflation of gas, it further depresses the heart, the myocardial activity. And hence, we try to avoid laparoscopic hysterectomy as much as possible and go ahead with subtotal, total, or vaginal hysterectomy wherever possible. Moving on to the next question. Most of you have got it right. It was quite a direct question, does not need much explanation. Which anesthetic drug is contraindicated in acute intermittent porphyria? Option A was propofol, option B thiopentone, option C ketamine, and option D etomidate. We have already asked the question on etomidate for adrenal suppression. The main thing to note about anesthetic drugs which are contraindicated in porphyrias are the drugs which cause enzyme induction are to be contraindicated. And thiopentone is one of the drugs which causes enzyme induction and hence contraindicated in porphyria. However, we also need to know that propofol is actually the drug of choice for acute intermittent porphyria. Moving on to the next question, you can see a figure associated with the question. On which principle does the following device function? The first thing you need to understand is that you need to identify the diagnosis and then think what the oxygen delivery device works on, what principle. The options were mainly Bohr effect, Bernoulli effect, Venturi effect, and Boyle's effect. Boyle's effect is associated with gaseous distribution. Rest 2 is not much importance in physiology. Venturi effect is also not of much importance, but you need to know this because the masks, Venturi masks, are named after the Venturi effect. What happens is in this condition or in this principle, basically, through a small nozzle, if there is a drop in air pressure, air is drawn from the source and hence mixed with oxygen. So this Venturi effect based on the nozzle size, there is color coding and hence it draws more air or from the source depending on the size of the nozzle and delivers it to the patient. Moving on to the next question. There is a figure from the net which shows nail finding. It's difficult because to appreciate this because it is not the normal and view from the top of the nail. It's a lateral view, like a cross section cut view of the nail, not exactly cut, direct front on view of the nail. If you appreciate that, you will be able to go with the diagnosis directly. And most of you have already gone with the correct answer. The correct answer was subungual hyperkeratosis. Onychosis, oil drop sign, Auspit sign. These are not the correct answers. Oil drop sign, however, comes with psoriasis only. Uh, Salmon patch and oil drop are one of the common mistaken things. So the things to know about psoriasis and nail findings is that there is a mnemonic called POISON, poison. So nail findings associated with psoriasis were nail pitting, which comes with P. OI is oil droplet sign. S being subungual hyperkeratosis, which is the answer here. O is again onychosis and N is nail plate dystrophy. Okay, we'll go to the second question of Dermat. There is another image showing red papular lesions all over the trunk, upper back. So we need to identify what is the diagnosis, and there is a clinical scenario given for the case. A child with sore throat infection, recent sore throat infection, who took amoxiclav, developed the following skin lesions. What is the diagnosis? So basically, the drug is given here to mislead you to the diagnosis, probably to fix drug eruptions. So some of you had gone that way. This is actually a psoriasis, and gutted psoriasis is known to be quite associated with upper respiratory tract infections like tonsillitis or pharyngitis. It's not Johnson's because it's not a bullous lesion, vesicular bullous lesion. It's not fixed drug eruptions because fixed drug eruptions tend to occur over ear, on the face, near lips, or tip of penis. So it has to be one of these, gutted or erythrodermic. The history of sore throat infection points to the diagnosis of gutted psoriasis. We can see pink to red scaly raindrop like lesions all over the upper back. So the name gutted means raindrop. Okay, moving on to the question number 13. A patient presented with hypopigmented rashes with satellite lesions as shown in the image below. What is the diagnosis? This was a easier question. For those who have studied leprosy, the thing which you will know that it is not a completely pure lepromatous or a pure tubercular lesion. You might, however, get confused between BT and BL, borderline tuberculoid or borderline lepromatous. You need to know that borderline tuberculoid is associated with finger-like projections, satellite lesions, and incomplete annular uh, lesions, not a complete closed ring. However, border in BB type of leprosy, we can see a classic Swiss cheese or a inverted saucer appearance. These two are important findings from leprosy infections. Okay, we'll move on to the next question. 14th one. Uh, this was also quite a bit tricky question, but there was diagnosis in the image. I saw it later. Could not edit it when it was going on live. So the ones who have noticed that might have picked it up, but this was pretty important and NBME question. So a child presented with ptosis of eye and the following presentation. What is the diagnosis? So we know that herpes zoster also involves a similar area. Herpes zoster and herpes simplex is given for to rule that out. Cavernous and capillary hemangioma, you need to know the important stuff about this. Capillary hemangioma is self-resolving, usually resolves within 6 months to 1 year. Cavernous hemangioma, however, needs treatment with laser. So the thing was capillary hemangioma involving upper eyelid or eyelid basically is known to cause mechanical ptosis and further cause reduced visual acuity and leading to amblyopia. So this might lead to refractive errors in the baby. So needs to be corrected as soon as possible. Usually, unless that happens, we usually don't need to operate on capillary hemangiomas because they're self-resolving. Okay, we'll move on to the next question. Question number 15. A truck driver with history of lesions on penis undergoing treatment presented with following rashes. What is the diagnosis? You can see polymorphous lesions. Some of them show crusting, probably due to uh, skin itching or something. And we also know that it is involving, it's not restricted to a particular territory. So the important thing to note was truck driver was a clue and history of lesions on penis was a clue. So drug eruption is a possibility if the patient only had a face lesion and lesion. However, we can see the lesions involving all over the body. So TN or SJS will be again a vesicular bullous lesions, not like polymorphous lesions as shown here. The answer, however, was secondary syphilis. Okay, we'll move on to the next question. Question number 16. A female presented with following lesions on lips, which is recurrent and is associated with fever. What is the characteristic feature on Zank smear? You need to be able to diagnose the lesion first, and then you need to be able to identify what uh, HPE finding is associated with the diagnosis. The options being HP bodies, acanthocytes, owli appearance, and multinucleated giant cells. This was a classic case of herpes infection, and we know that it is associated with multinucleated giant cells on Zank smear. Aulai, which is associated with CMV, is not a correct option, and HP body small as contagious some associated lesions are not the right answer here. Moving on to the next question, question number 17. A 40-year-old female presents with diabetic foot ulcer. This was a recent NBE question and quite controversial, but we need to know that this might be adopted into our Indian settings. So, sterile probe to base of lesion is likely to show what? Staph aureus, Staph epidermidis, Pseudomonas, or polymicrobial infection. Uh, the important thing to note is that diabetic foot ulcer with superficial ulceration is usually known to have culture on culture staph infections, staph organisms are seen on culture. So it might be staph aureus, which is more common, and staph epidermidis. However, since we know that this was taken, the probe was taken from the base of lesion, which means that the ulcer is quite deep. The option was polymicrobial, and from deeper parts of ulcer, usually polymicrobial organisms are cultured, mostly gram-negative organisms. Moving on to the 18th question. Uh, I think the question, okay. A 24-month-old child presented with excoriated rash on groin and ankle. Rash on an inner ankle was successfully treated with topical clotrimazole. So this was a clue that this was a fungal infection. However, they also gave that the rash has reappeared. What is the mechanism of infection? So most of you have gone with immunodeficiency. Some of you have also gone with infection, and some of you have gone with incomplete therapy. So incomplete therapy is ruled out because we have seen that the patient was successfully treated already. So even the resistant lesion is ruled out here. So there is a conflict between option A and C, which is immunodeficiency and autoinfection. The important thing to note here is there is excoriation. Excoriation itself means that the child is unable to bear the itching, and hence he has itched and caused auto-infection, repeated infection. For the time when he was taking treatment, the lesions have disappeared. However, because his nail might have carried the organisms, the nail beds, also after stoppage of therapy, he has got reinfected, and hence there was a recurrence. This was also an NBMA question and quite an important tricky one. Okay, this question should have had an image, probably disappeared somewhere mid in between. This was actually a case of sporotrichosis with showing the lymphangitic spread, which is classical for sporotrichosis. What is the mechanism of the following condition was asked in the question. So most of you have gone with systemic mycosis as the option also, but we have not asked the diagnosis here. We have asked the mechanism of the following condition. So the mechanism, however, was the lymphangitic spread. The lymphangitic spread had led to the typical distribution of sporotrichosis along the pathway of the lymphatics. Vasculitis and pre-malignancy were not an important options. Moving on to the last option, this was one of my favorite questions. Most of you would have not heard of this question, but it is quite important. When you think about Mycobacterium avium intracellular, you always remember one or two stuffs: immunocompromised, Lady Winterberger sign, Wintermeyer sign, where there is cough suppression and middle lobe infection, bronchiectasis. However, one more important thing to know that MAI is associated with lymph node infections, lymphangitis of the neck, and the preauricular lymph nodes. So it is given that the patient had renal transplant, so it's obvious that he's on immunosuppressants and hence in a state of immunodeficiency. Also, the patient is presenting with classical preauricular reddish lesions. There was no mention of HIV or other infections. HHV8 is not much common in this part of the skin. and this looks indurated. So this
ಎಲ್ಲರೂ ಯಾಕೆ
is
ಹಿಂಗಿದಾಳ?
actually a lymphangitic infection. So the correct option was Mycobacterium and avium intracellular, and only one of you has have got it right. This was quite a tough question. Anyways, this was a good session. Most of you have attempted it sincerely, and I wish you all the best. We'll meet you in the next week with another set of 20 to 30 questions. Hope you all prepare well, and we will make sure that more number of people join. All the best for now.